In the current era, we are talking about new generation stents, which are thinner stent struts, and also having people who are at a high risk for bleeding because the incidence of atrial fibrillation is on the rise, and people who have atrial fibrillation also can have coronary artery disease and might need stents. In such a scenario, we are always in a dilemma: how many people should be on a dual antiplatelet therapy or triple therapy, which includes aspirin, clopidogrel or ticagrelor, and some sort of anticoagulation, whether Coumadin or the direct oral anticoagulants. I think the future is going to be actually shorter duration of antiplatelet therapy, and probably people with atrial fibrillation and who needs stents could have a certain type of stents, such as we are doing a trial called Cobra Reduce. We are trying to see whether we can shorten the antiplatelet therapy to even 14 days. It is similar to a bare metal, but has a coating which is a PZFE coating, and it actually prevents it from restenosing much. So the rates of restenosis are lower, and at the same time patients don't have to be on longer antiplatelet therapy, which can put at a risk for bleeding. So now we come to a fine balance of probably giving them the best stents, at the same time not having to increase the risk of bleeding. Yeah, so the mitral valve technologies are in development. Currently, FDA approved transcatheter mitral valve repair with the Mitra clip for mitral regurgitation. And as we know, mitral regurgitation is at least 3 times higher incidence than aortic stenosis, and we are now able to treat all types of aortic stenosis with the transcatheter aortic valve replacement. And even though we are addressing a certain group of patients with mitral regurgitation with the Mitra clip, but the future really lies if we can do a successful transcatheter mitral valve replacement. And to achieve that, we have to finally see what are the problems that we can have with this mitral valve, because the mitral valve is asymmetric, it is D-shaped, it is the shape of the mitral valve changes with the systole and diastole, and as well as we have to fixate the valve successfully. In aortic stenosis, there's a lot of calcium, whereas in mitral regurgitation, there's no calcium. So we need to have an ideal valve that can fixate on that. Even after doing a successful mitral valve replacement, we have seen problems that are risen because of LVOT obstruction. So left ventricular outflow tract obstruction can be caused because of the valve that is impinging towards the LVOT, and can cause either a similar picture as a hypertrophic cardiomyopathy or aortic stenosis. So now we are trying to understand with imaging technology such as CT scan and virtual valve implantation, we can probably put a valve in the mitral valve and see with artificial intelligence and evaluate which patients will have LVOT obstruction or not. By predicting that, maybe we can address that people who are going to have LVOT obstruction can be treated with alcohol septal ablation and then be brought back a month later for mitral valve implantation.